Both septal bounce and septal shudder are hallmark echocardiographic findings of constrictive pericarditis. While they look slightly different on an echo, they are driven by the exact same hemodynamic mechanism, enhanced ventricular interdependence within a fixed total cardiac volume. Because a scarred, rigid pericardium prevents normal free wall expansion during diastole, the heart operates in a fixed space. Any change in filling volume in one ventricle must happen at the direct immediate expense of the other. The septal bounce is a macroscopic early diastolic shift of the interventricular septum towards the left ventricle. During inspiration, negative intrathoracic pressure increases venous return to the right ventricle. Since the RV free wall cannot expand outwards against the constricting pericardium, the rapid early diastolic filling physically forces the septum to bow leftward into the LV to accommodate the volume. On MO or 2D imaging, parasternal short axis or long axis, you will see an abrupt leftward motion of the IVS during early diastole, which then bounces back to a more central position as filling pressures equilibrate later in diastole. While related to the bounce, a septal shudder is a high-frequency, rapid, multiphasic trembling of the IVS. This typically occurs during isovolemic relaxation time or immediately following atrial contraction. Because the pericardial space is fixed, the instantaneous pressure gradients between the RV and LV during these transient phases create a brief tug of war. The septum acts as a flexible membrane vibrating rapidly between two rigid pressure-locked chambers as walls open and close. On a mode, it presents as a transient shivering or notching of the septal line right as the ventricles transition into diastole, often occurring just before the more pronounced macroscopic bounce. When evaluating a patient with heart failure and preserved ejection fraction, differentiating constrictive pericarditis from restrictive cardiomyopathy is notoriously difficult. RCM lacks both the shudder and the bounce because the pericardium remains compliant, meaning the ventricles do not share the exaggerated interdependence seen in constrictive pericarditis.